Thanks so much for having us, Donna. It was a little nerve-wracking at first being on the podcast, but once you get into it, you get into the swing of it, that's for sure.
You were such a wonderful moderator, linking a lot of different points that we made in a very natural way.
Yeah, you have a real talent for it. I was like trying to think of your next question so I'd be all ready, because I'm not used to doing these, so it was a little stressful.
Well, the three of you really are inspiring, and we never know where something's going to go. Primary care is seen by many as the heart of the healthcare system. In rural and northern communities in Ontario, where more than half of long-term care spaces still need redevelopment, there's a growing need for strong, team-based care that connects people across settings. In these communities, long-term care homes may not always have the same resources as larger centers, but they are rich in ideas, innovation, and collaboration. Care teams are finding creative ways to keep older adults healthy, connected, and living with dignity close to home. Joining me for this conversation are Dr. Tara Kieran, Michelle Lajeunesse, and Jennifer Burns-West. Tara is a family doctor and leading primary care researcher in health system innovation at Unity Health and the University of Toronto in Canada. Tara helped to launch Our Care, a Canadian survey that inspired Ontario's new Primary Care Act, a major step in transforming how we deliver care in Canada's largest province. Tara is also host of a new podcast, Primary Focus, with Dr. Tara Kieran. Michelle Lajeunesse is the executive director of the Marathon Family Health Team in Marathon, Ontario. That's about an 11.5-hour drive north of Toronto. Michelle has seen firsthand how team-based care and innovative, more holistic approaches to prevention and social supports are helping older adults stay well and supported in their communities. Jennifer Burns-West is the interim CEO of Haliburton Highlands Health Services, where they are leading in building integrated health services and redefining rural healthcare in Ontario. Jennifer is also a board member of the Senior Care Network and is passionate about optimizing technology to enhance service delivery. Most recently, Jennifer has worked to revitalize care options for residents of Haliburton, exploring global best practices such as green care farms in the Netherlands as a potential unique healthcare offering for Ontario's rural communities. Outside the bright lights of big cities, resourcefulness and partnership are driving grassroots innovation. Inside suburbs and urban areas, policy is now catching up to lived experience. In this episode, we'll explore how sharing wisdom, testing new models, and building a more responsive primary care system can strengthen seniors' care across Ontario, including in our long-term care homes, where collaboration is helping residents live well every day. I am super excited to be able to welcome three remarkable women to today's podcast. I'm really delighted to have Dr. Tara Kieran join us, Michelle Lajeunesse, and Jennifer Burns-West to really start the conversation or continue the conversation that we've tapped into on a number of our episodes around how do we learn from one another? What do we need to be thinking about as we think about system reform in Ontario, Canada? The government of Ontario has actually appointed Dr. Jane Philpott, who has been a guest on one of our earlier seasons when she was with Queen's University in Kingston, Ontario, Canada, to really spearhead a movement around primary care reform as an anchor to bigger systemic reform in the province of Ontario as we contemplate how we navigate an aging demographic, as well as how do we navigate health human resource shortages, which again has been a topic of discussion on this podcast. I'm going to maybe start with you, Jennifer, as you think about the healthcare challenges for older adults in a rural community. So you are sort of a near north, for those who know the geography of Ontario, but you're also rural and you represent a very large rural community.
So Haliburton Highlands borders on Algonquin Park to the north and City of Kawartha Lakes to the south. We are considered Southern Ontario, but as Donna mentioned, we are rural. our community struggles with lack of public transportation and lack of primary care and really being able to access care and have equality of care for residents compared to someone lower in Ontario, closer to the GTA. We just recently got a CT scanner last year. So we were sending 4 people every day, an hour and a half to the south to get a CAT scan, which really in today's standard is the equivalent of having a blood pressure. So it's really been a game changer for us in the fact that we've now been able to recruit more physicians and nurses as well because of the enhanced technology and bringing care closer to home. And I think that's really important for people in a rural setting to have the equal access to care.
And you do have an older demographic in your local community as well. And I know you operate not only a hospital and other community services, you also have a long-term care home.
Yeah, we're kind of a unique organization, HHS. We have 3 sectors. We have community support services, 2 long-term care homes, and a hospital, which includes an acute care unit, as well as an emergency department. And that gives us lots of flexibility to be creative in the care that we have. It also poses a few little challenges along the way, but we're really focused on being the anchor for healthcare in Haliburton County.
And Michelle, you are joining us from Marathon, Ontario. So you are in Ontario's north and the real north. And congratulations to you on your new role as the executive director of the Marathon Family Health Team. I'm curious as to your thoughts on what are some of those unique challenges as you think about a northern and rural experience as we navigate health system challenges. I know that a lot of our innovation actually in Ontario has been spearheaded in the north and that there's some unique opportunities that perhaps we could all learn from.
Yeah, absolutely. I think Jennifer touched on a lot of really great points. And maybe just so that listeners have a better understanding of where exactly Marathon is located, we're on the shores of Lake Superior. And the closest cities or urban centers closest to us are Thunder Bay, which is 3.5 hours west, and then Sault Ste. Marie, which is 4.5 hours east. So we're talking about rural, remote communities. Marathon is a great example of that. And I think in terms of some of the challenges that older adults who are living in northern and rural communities in Ontario, there's just a lot of overlapping challenges that make their health needs more complex. So often older adults in these regions, they'll experience higher rates of chronic conditions like diabetes, COPD, and heart disease, and many are managing more than one at a time. And in fact, data consistently shows that these rates are higher in Northern Ontario compared to the provincial average. And lifestyle factors also play a role. So there's lower levels of physical activity, poorer nutrition, higher tobacco use, and greater alcohol consumption that are also more prevalent in Northern Ontario, which can also increase chronic diseases and complications associated to that. But these challenges aren't solely about personal choices. They're also really closely linked to the social and environmental realities of living in the north. For example, lower average incomes, limited transportation, like Jennifer referred to, harsh winter weather. So those all influence health outcomes and can create barriers to maintaining health for the overall population, but specifically for older adults as well. So those are definitely things that we need to be aware of for those of us working in primary care, is what the health of our population is looking like and what makes them at higher risk of chronic diseases, and where can we focus our efforts in terms of that preventative care. And I think that preventative care can also be a challenge in our communities, largely due to workforce challenges and resource limitations. So in larger centers, for example, care teams will have access to physicians, nurse practitioners, but also allied health professionals like dietitians, kinesiologists, diabetes educators, maybe pharmacists embedded within their primary care teams, and other specialists who focus on prevention and overall well-being. And they offer programs that help older adults stay active, manage chronic conditions, access early screening. They'll offer this through programs like exercise coaching, nutrition counseling, mental health supports. But in smaller communities, these services are not always available, again, because of workforce shortages and just inability to recruit and retain qualified healthcare professionals. So that can sometimes mean that these types of programs can be inconsistent or just absent in some cases, which does create some inequities in access to the kind of proactive care that helps seniors stay healthy, independent, and engaged in their communities.
That's so insightful as you think about the complexity of the actual ecosystem that you're trying to actually function within. So, Tara, you spend your day job actually thinking about primary care reform and system reform and those system dynamics more broadly. You also have a podcast called Primary Focus that you have framed as reimagining a healthcare system that works for everyone. And listening to Jennifer and Michelle talk about the context within which they are operating, I'm really interested in your thoughts about some of the broader systemic challenges that can be brought to bear as we contemplate how do we make sure there's equitable access, that we are supporting individuals who are living and aging in our rural and remote communities, but also what are some of those lessons learned from perhaps our urban communities where we can really start to support one another.
Yeah, thanks for that. I mean, I think I myself, just to situate myself, I work and live in Toronto, and so bring a different perspective than Michelle and Jennifer. But we'll say that in my experience, also working with other healthcare professionals as well as patients and the public, I mean, although there are differences in context between our urban and rural geographies, there are actually a lot of similar challenges that we are facing. And so we know that access to primary care is just a problem across this country. And that's true both in rural areas as well as specific pockets of urban areas. And we know that both rural and inner city type of, I say inner city, but actually it's usually the outer suburbs. So both rural areas and some outer suburbs are actually don't have as much primary care capacity per capita as some other areas in Ontario. And there are, of course, distinct reasons why it's more challenging in rural areas compared to why it might be more challenging in an outer suburb. The reasons would potentially be different, and Michelle spoke to some of these. Recruiting people to live in a rural area where they may not have roots or ties can be really challenging. At the same time, I will say there's oddities related to how Ontario's system has been set up, in that family health teams, for example, are more likely to be rural than they are to be urban. And so we do also have some capacity in rural areas that has been built over the last 10 to 15 years, but that hasn't really been grown to the full extent. So just to take a step back then is just to say that access to primary care is a challenge, definitely in rural and northern areas, as it is in many other parts of the country. The solutions to it, though, may be different. So some things are the same. We need more health professionals. They need to work in teams. But how are those teams constructed exactly? And how do we retain and recruit those professionals might look different in northern and rural areas. But I think some of the other things that I'll put forward are similar challenges, include things like access to information. So we heard from patients and the public that it was so frustrating not to be able to have access to their own health record. And that was one of the recommendations that our people we engaged with put forward. And that is particularly true, I think, in northern and rural areas as well. So if you are going from different facilities for different tests, you really need to have your own record with you so that you have that continuity of information that you can share with your clinicians. And as we're talking about older adults in particular, often there are family members involved in supporting that older adult in care. And so again, really important for that older adult to be able to have that information for themselves that they can share with the caregivers that they choose to share it with. And then I think, Michelle, I'll just build on your point around this. You talked, I think, a lot about the social determinants of health. And just to say that when we spoke to patients and the public, they really wanted to see a system that was wellness-oriented and not sickness-oriented. And so that does require us addressing social determinants of health. And I think you just put forward some of the real distinct challenges in Northern Ontario in particular that need to be considered when we think about that. But, you know, the recommendations we heard from patients in the public were around connecting primary and community care and services. And I really see that potential when we're thinking again about older adults, where there's a range of chronic condition needs potentially, and you want to have primary care connected to the organization that might be supporting mental health care, that might be supporting fitness and exercise. So you want all of those organizations to be able to be interconnected, or at least to know what each other is doing. So those are just a few points, though, that I think we heard across the country when we were doing patient and public engagements, that I think true for people across Canada, but then have a specific flavor, I think, when we're talking about older adults in northern and rural areas.
One of the things that we often hear about in Canada is that for long-term care, for example, 30% of the people who are in long-term care could actually be served someplace else. The recent data would actually suggest that in Ontario, actually, it doesn't just suggest, it indicates that Ontario, it's actually less than 5% who could be supported and housed in a different environment. Where we actually see that spike that actually brings it up to 5% is actually in our rural and northern communities where there are no alternatives. So we're seeing people moving into a long-term care home earlier than they perhaps otherwise would need to because there are no other supports. The challenge that certainly we're going to see now, though, is with the population over 80 doubling in the province of Ontario by 2027. So that's just over a year from now. The preventative aspects of providing primary care, we're too late for this population. And so with a wait list of 48,000 people for long-term care in the province of Ontario, we recognize that even though the government of Ontario is investing billions of dollars in new long-term care homes, renewing old homes, building new spaces, supporting new models, how do we deal with this urgent pressure that's facing us today? And we know that in our rural communities where that older demographic is going to spike, the pressure then on primary care providers and on other community supports and on the family caregivers in those communities. What are some of those considerations that we're going to have to make, knowing that this is here? The silver tsunami, it's not coming. The waters are receding right now, and the wave is about to crash. So there is this opportunity, I think, of urgency that, especially with thinking differently around how a community can come together to respond, I'm really interested in hearing your thoughts, each of your thoughts on where could we put that elder care ecosystem in place, knowing that we are renewing long-term care homes, but we're not going to build enough spaces. And this is just another chunk of that puzzle that seems to be very isolated from the rest of some of the other services and supports. Tara, why don't we start with you?
Yeah, Donna, I mean, those are such great points that you've made. And as you were speaking, I was actually thinking about some work that I led a few years before the pandemic. So I think it's probably around 2016, maybe 2018. I worked with the provincial government agency, Health Quality Ontario at the time, to ask patients and caregivers across the province about their transition from hospital to home and what impacted their experience and what should be the biggest focus for improvement. So we did this research process called concept mapping, where we really reached out very broadly to understand kind of those concepts of what influenced people's experience, and then had them rate what was the most important to them and in terms of what they thought the province should focus on in terms of improvement. And what was really interesting is that the answers were pretty clear and consistent. Among the top 5 things people wanted to see addressed was home care and home care. So not enough home care to meet the needs, that home care wasn't available in a timely way. And then I think there was another piece about home care as well that I'm not remembering quite right now, but it was pretty amazing how consistent actually that response was across sociodemographic groups. And one of the things I also noted is that we actually did include long-term care residents in the people we reached out to. And they really strongly identified home care as something that was lacking and that they needed more of and that needed to be addressed. So not having enough home care to meet the need was in particular, one of the most important things for people living in long-term care. And I've reflected and thought a lot about that. And I'm not sure exactly what is behind that ranking, but I think one of the pieces, is that perhaps they're reflecting on their own experience that they wouldn't necessarily have to be in long-term care if they had that home care available to them at the time, for example, when they had a terrible illness that got them to be hospitalized and then they needed to go home. Part of what we found could reflect that. The other thing that could be reflected there too is that even when they go back to their long-term care home, which is their home, they're not necessarily receiving the supports to the degree that they need to, given that they've maybe had a change in condition coming out of hospital. So, but just to put forward that, Donna, your comments made me really reflect on the importance of home care as a strategy that we need to invest in to support older adults across the province be able to thrive and live with dignity. I think the other piece I'll also throw in is I have had a chance recently to visit some other countries, including Denmark, where I have to say they seem to do elder care right. Even visiting a long-term care home there, they're beautiful and full of light and services that in a way that I haven't seen consistently in Ontario. But then when it comes to home care, they have much more organized services for home care that do actually speak to as well with primary care. So although they're separate from primary care, there's good communication back and forth. And there's also good kind of service, not just 9 to 5, Monday to Friday, but actually all through the time, including if you have an urgent issue. So just to say, there's a lot we can learn from others, but home care is definitely something we need to address.
And that's something that we certainly hear from an aspirational perspective where people do want to stay at home as long as they can. And we've been talking about aging in place is aging in your community and whatever is the appropriate care setting. I know from my own personal experience, we were able to support my father at home with living with Alzheimer's until we couldn't. And then that happened really quickly, unfortunately, but that's the reality. So how do we make sure those services are there? And we are very excited that the new long-term care homes are not the long-term care homes of 2019 or even 2020. The new homes really are coming together in a remarkable way and starting to see more of a hub model with other services being provided. And Ontario is piloting community access to long-term care where you can come in and get services but also have services go out, similar to a model that we've spoken about on our podcast with our colleagues in New Brunswick. We clearly need to do better. And Jennifer's been nodding her head for our audience as Tara was speaking about the importance of home care and public sentiment. So Jennifer, please amplify your nods.
I think home care, the silver tsunami is growing. The wave is, I think, crashing down in Haliburton County and will increase over the next couple of years. And we struggle with home care and supporting people at home. And even to get people out of the hospital, everyone that's being admitted into long-term care is a crisis placement. There's increased behaviors and comorbidities and poor mobility. And with our ALC rates higher in the hospital, could some of those people be managed at home with appropriate home care? I absolutely agree that yes, they could. We're very fortunate here in Haliburton County that we do have an assisted living program where we're able to transition some people home. I think we need to have people live with purpose. And I was fortunate enough, we have a partnership with McMaster University and Dr. Sharon Kalistian, and we went over to look at the green care farms in the Netherlands last spring and how they incorporate adult day programs as a transition into long-term care, giving people a purpose to go every day, remain active with activities of daily living. There was one gentleman there that was gardening for the whole 3 hours we were there for the tour. It really warms my heart because he thoroughly enjoyed himself and he had a sense of purpose every day. And I think some of our elderly in the community lack that. They get up in the morning, they sit in front of the TV and watch CNN. Whereas they have a lot to offer. They could go out and volunteer. And we were really fortunate this summer. We had an intergenerational day camp at Haliburton County Hospital for our staff and physicians' children in conjunction with our adult day program. And we did some intergenerational programming. And we had one lady who was a retired school teacher who started a little reading group with some of the kids. And we had another gentleman who went go-karting because one of the kids wanted to go, but he was afraid to go by himself. So the gentleman went with him. And it was really great to see elderly people in the program come alive with the young kids there and The younger kids learned a lot too. It was a really successful program, and we're looking at incorporating it next summer as well as March break. There was lots of benefits that came out of it. And I really think that we need to get creative about how we do care in Ontario. Not everyone needs to be in a long-term care home. They call it a nursing home, and they may have comorbidities and illnesses, but they're not sick, right? In the Netherlands, they have more care providers, more like PSW and home support workers that are caring for people. And it's not so much of a medical model. And I think that's something that perhaps if we get creative and innovative here in Ontario, that we can incorporate, because they're not sick. Maybe they can't manage in their own home, but they're still living a productive life and just need to be in a different spot with a little bit of extra help.
It's always great because we're thinking about some of these other approaches. What are other countries doing well? What can we learn from them? Again, though, I do think we can learn from some of our colleagues in the North. And I'm curious, Michelle, home care has always been a challenge in the North from an HR perspective, but also just by virtue of distance. I'm curious, in your experience, how do we better support our elderly? Where could long-term care in the home, maybe we have to redefine what long-term care is, but what's the Northern experience?
Just because we're talking about long-term care and new long-term care builds in Marathon, we have a new long-term care home that just opened 2 weeks ago. So we have some residents moving in now. It's a 14-bed home. So we're really excited about that in Marathon. And just to go back to some earlier points just around to services and home care as well, is that what happened in Marathon before is that there were people who were in level of care and couldn't go home, actually couldn't get discharged because that's what they needed was PSW support. So we could have provided nursing, but again, had to stay in hospital where they didn't necessarily have to be because of that lack of support. And I think for us in rural communities, we do have home care programs in some communities. And again, there's limited capacity there and it looks a little bit different. But when we're talking about home care, it really is about more than just nursing and PSW services. We're also looking at physiotherapy and occupational therapy. And that the collaboration amongst those different disciplines, I think, is what really makes a strong home care program. And we don't have consistent access to all of those different disciplines. And what I think would work better in rural communities is actually to have home care embedded in primary care. It would allow more consistent access. We would be able to get more creative with the home care that we provide and not have as many barriers that are associated with home care programs the way that it's currently set up. So I think that when we're looking at the investments that are not only going in long-term care, but in primary care right now, looking at expanding teams, I think what a great opportunity to look at home care and how that could potentially be an expansion of primary care in these small communities where we know what our community members need. And we are in I believe, a better position to be able to offer those more consistent services to members of our communities and be able to provide that team-based care and that environment that I think would be a better recruitment and retention tool for those healthcare professionals that we're looking for to build a more robust home care program for our communities.
It's interesting that you're talking about sort of running that through primary care. I know we actually have some long-term care homes in the province of Ontario who operate some home care. We're seeing different models emerge. And we also, so in Toronto, we have UHN at home. We have Sunnybrook at home, where hospitals are partnering with home care providers to support transitions from hospital into community. I'm curious as to your thought on how do you enable some of these new approaches and thinking about where and how home care gets delivered. We have structured silos, largely funding and regulatory silos. How do we bridge them, and wherein lies the opportunity? Is it just about greater collaboration and finding like-minded souls, which I think a lot of our innovation has come through people having conversations? How should we be thinking about driving some of these change and better integrated approaches?
I think the hard answer here is that there are so many things that we need to be doing differently to get to that better state. I really applaud local innovators. At the same time, we don't want a system that's reliant on local innovators to do better. We really need a system where everybody is able to no matter their background or where they live, be able to know that they can rely on a certain base level of quality of care, right? And I think part of the problem now is there actually isn't a good definition across the province around what is it that you're an older adult, you're at home, like what is it that you should be able to expect from the healthcare system that's publicly funded? What should you be able to expect relative to your needs? I will say that there have been important processes over the years to try and actually define that, but we haven't gone the further step to actually enact it. I think, to be honest, my own husband, Dr. Irfan Dalla, he was like part of a process that he led together with someone who was part of the leadership of CCAC at one point, looking at, and they published a report looking at the levels of care. What are the levels of care that someone might need to receive through home care? How would you define that? And partly just putting forward what are the services that then should be able to be expected for different levels of care that people require. And we need to have some transparency around that. So just to say that there were processes in the past that have tried to define a certain level minimum of what we need, and we need to go back to those processes so that we have a clear understanding across the province so that people know what to expect. As part of that, I do think that we need to retain that patient and public focus because sometimes we can get mired, I think, in the details of what doesn't work to us from a provider lens, for example. But ultimately, patients and the public need to have their own record. They need to be able to direct their own care plans. And they need to understand what is happening for their care. And I think those very basic things are actually not happening. And then ideally, the team around them is communicating. And I would say, just building on some of Michelle's comments, the lack of integrated systems is a real problem right now. As a family doctor, I would say, for the duration of my career as a family doctor, which has been more than 20 years now, I have not gotten communication consistently from home care nurses or PSWs, even when I order the care. And that's not because these people who are doing the care are not doing their job or anything like that. It's because our systems are actually not designed to do something that honestly is actually just common sense. If a doctor is asking the nurse to go in twice a week for a blood pressure reading or to look at a wound, of course the doctor would like to have some response about how that progress is, and the patient assumes that their care team is talking to each other. So I guess I'm not really answering your question, Donna, just to say that there are so many things that are needed, from setting the level of where it is that we want, what transparency, so that people have a sense of what it is that they can expect. And that's consistent from region to region. And then I think continued quality improvement, and that requires measurement. And I would say patient-reported measurement is one of the most key pieces here. And I think we haven't been doing a good enough job on that metric. I definitely think we need to stop thinking about our siloed role and instead focus in on what it is that the patient needs. And I do agree with Michelle that what has happened so far when home care as a separate entity hasn't been working. And so whether home care is integrated with hospitals or primary care, I think having home care integrated into a sector where they're able to at least then be part of that sector more effectively, I think was working better than what it is that, to be honest, we have in most areas now. So those are just a few things I would say putting out there. And then the last thing I will say is that there's definitely a funding issue. Publicly funded home care does not get enough dollars, and that needs to be the case. And part of the issue related to home care in particular is that we have a number of racialized women who are making up the workforce for home care. And we saw through the pandemic that we as a society are okay with them doing the really hard, dangerous work without actually getting the pay that should go to that. And I have actually, I'll say, a number of patients who are PSWs that work in home care. And it's terrible. They don't have actually ongoing jobs. They don't have job security. They don't get paid really for commuting time between places. They're really taken advantage of, I think. And often these are new immigrants who are really often, to be honest, in my own practice, they're single moms really trying to make things work. And so we need to do right by the workers within home care to retain that workforce if we really think that it is important.
We need to build and retain the workforce, especially given that the increasing demands as we think about the older demographic that will need more support and will have more chronic diseases. You touch on an interesting point, Tara, and this is something that really resonates for us within the Ontario Long-Term Care Association. We recently did a poll of almost 6,000 Ontarians across 6 regions. We really wanted to dig in and get a feel for what's happening in rural northern communities, not just in our urban centers. And it followed on a poll that we did 2 years ago with only baby boomers between the ages of 65 and 75 were surveyed around their expectations around their own health. And the majority 2 years ago, not surprisingly, said they will not be getting sick. They will not need more specialized health care because they're fit. They're going to be just fine. This time, we did a general population survey, and interestingly, the number of people who thought that they might need specialized care at some point actually increased. So there was more of a, maybe I won't stay perfectly well. That being said, when asked if they'd planned and made any plans or had any expectations around any specialized care, what that would look like, their response was that the government, and that's actually all 3 levels of government together. They didn't differentiate. The government would make sure that the services and supports would be there. When asked what their expectations were, if you weighted what they wanted most and what mattered most to them, was it access to care? Was it the quality of care? Or was it the affordability of care? They weighted all 3 equally with the expectation that if they did need care, it would be available for them in their local community. They did not want to move. There was an expectation that regardless of where they lived, and it was equal urban, rural, northern, it would be there locally for them. It would be high quality. So just the general assumption that any care would be high quality care. And affordability was interesting in that they were agnostic as to who delivered the care, either private delivery or public delivery, so long as it was all publicly funded. And they made no financial plans for any kind of private care. And they had no expectation and had not made any plans with their family members that their children or other family members might be required to support them in their caregiving journey. So there is an expectation management challenge that everyone will be facing. And so having the discussion around what's available and what could and should you be expecting in terms of your access to care. Jennifer, I know you talk about making sure that you've got a nice continuum, a campus model where you're really providing sort of more of a biopsychosocial approach to your local community. But I also know that you have people from outside your community who are accessing your long-term care spaces. So just being able, even we think Toronto has access. So when somebody from Mississauga is going to, or Brampton is being moved to Halliburton because there's no care available for them in their local community, we're starting to see people move around. And I know, Michelle, this has been a phenomenon in the North for a very long time. So I'm just curious from Jennifer and Michelle about how do you manage expectations or understand or communicate? Because that communication is key. So maybe we'll start with you, Jennifer.
So I think people have to advocate for their own healthcare. And I don't think people realize that they need to speak up and make their goals known to those that are caring for them, because that's the number one way that they're going to get the quality of care that they want. With regards to long-term care, people fill out the wait list and they can choose any bed in Ontario. Sometimes I think it's a sign of the system. They're in crisis at home. They can't access home care. They don't have the funds to privately pay. They can't expect their children to quit their jobs to look after them. And they're so desperate, they take the first available bed. And that might be coming from the GTA up to Haliburton County. But then you look at the people who want to live in their community as they age and leverage a long-term care home, closer to their family, because their wife doesn't drive. There's no public transportation. They're socially isolated. They have nobody anywhere else. And in some communities, there's only 122 beds. So it's not fair for those people living in that community to have to perhaps choose a bed outside of their community because somebody else is coming in. I get the whole preface that the bed is a bed, but when you're in rural Ontario, there's a lot of isolation with regards to lack of transportation, the age of our population, the lack of poverty as well. People don't have the means to drive an hour to visit their mom, or do they even have a car to drive? So I think it's really important that people have options to age at home, and we should be maybe backing it up and doing things more proactively so people can stay in their homes longer. So leveraging social prescribing, leveraging adult day programs. It is a dream of ours as we evolve our long-term care home and our adult day programs with intergenerational care, is looking at an overnight respite. I think people think adult day program, it's a break for the caregivers and it allows them to have some time and manage the person at home longer. But really, sometimes you just need a good night's sleep. So should we be offering overnight respite so that those caregivers at home are able to get a good night's sleep and then look after their loved ones during the day? Because being admitted to a hospital and being ALC is not in the best interest of the patient. For every day that someone's admitted in the emergency department, it extends their length of stay by 2 to 3 days, and they decondition, and they don't have purpose, and they're not up and walking, and there's no recreation programs in the hospital. And I think we need to do more in the community to keep people safe and engaged so that they're not coming into the hospital and then waiting for long-term care. It might decrease the crisis placements coming through from the hospital sector. I think we have to be creative and think outside the box. And long-term care is heavily regulated. And is there some opportunities there to look at doing things in a new and innovative way and leveraging technology to work smarter and using the technology to our benefit so that you can access information from point-click care while they're in the hospital, or vice versa? We should almost have one system that's attached to the health card. So when you swipe your health card, your whole story comes up and people are able to document that way, because we struggle with lack of transparency with information. And people in Haliburton County, there's one EMR at the family health team. We have Epic in the hospital, which is great. We're able to communicate with other Epic hospitals, but then our urgent care uses a different EMR, but being cared for by all the same people. So you can't get a good picture of what's coming on, what these people are facing when they're coming in to get care. But I really think, going back to what Tara said too, I just wanted to, it was fresh in my mind, home care. If people were paid appropriately, we wouldn't have a shortage of home care workers. It's disproportionately lower compared to hospital and long-term care rates. And that is a struggle. They get paid by the person. They don't necessarily get appropriate mileage. And in rural, and I'm sure Michelle knows this, you might have to drive an hour and a half to do one visit in rural Ontario, and driving around lakes and stuff. It's not exactly a straight road. So paying people for their time rather than just by the visits. And I think if we looked at that lens, we might get more buy-in for healthcare providers to work in the home care sector to provide care for people in their homes to avoid unnecessary long-term care admissions or hospital admissions.
Yeah, Jennifer, you touched on so many good points. I'm going to try to remember all the things that came to mind as you were speaking. But going back to your original question, Donna, I don't have too much insight in terms of what providers have been doing to prepare their patients in terms of expectations in the community as they age. But what I have heard are some stories about older adults choosing to move to Marathon without realizing, oh, I have to drive 3.5 hours to get to my specialist appointment, or I don't have access to an MRI or CT scan here, and just really not recognizing the challenges associated with living in a rural community before choosing to make that move. And sometimes people are choosing to do that to be closer to family and things like that, and maybe don't always take the time to stop and think about their healthcare and what that might look like in that community, which I thought was interesting. Maybe just from my perspective with a background in health promotion, I was really drawn to Jennifer's comments just around the social prescribing, because I think that piece about caring for seniors goes so much more beyond that medical care that we can provide as a system. And I think that embedding programs like social prescribing in primary care can really help connect seniors to things like exercise programs, meal delivery services, transportation to get them to appointments in urban centers, connect them to volunteer opportunities and just other community resources that help keep them active and engaged. And maybe I'll just share a few examples of what we've been successful at doing here in Marathon. So we have group workshops and education sessions that we try to offer on a regular basis that have a dual purpose. So we want to share information and teachings with our community. For example, in November, it's Falls Prevention Month. So we have a falls prevention workshop where we invite older adults to come to our primary care clinic. We have our healthcare providers there sharing information about safety, mobility, and health promoting behaviors. But at the same time, it provides them with an opportunity for that social connection and to learn from each other's experiences. We also have an indoor walking program that we run in the winter months. We were talking about the weather a little earlier where it gets really cold in Marathon. There's lots of snow, icy sidewalks. So a lot of older adults are looking for a safe and a warm place to walk in the winter. So with this program, it's open to everyone in the community, but a lot of seniors attend. And this too serves as a dual purpose. It allows them to stay active in the winter, but also have that social connection with other seniors and other like-minded people. And because it's a volunteer-run program, a lot of seniors take part in running the program themselves, which builds both community and a sense of purpose. And maybe the last example I'll share is we have a new program that's called Preventative Care for Quality Aging. And again, this is going back to some of Jennifer's comments about being more proactive. And what I think is unique about this program is that often when we're talking about programs that focus on quality aging, you'll hear about programs like falls prevention, and they target people that are age 60 or 65. But quality aging starts so much earlier than that. So with our program, it's open to anyone 40 years and older. And it's all about giving personalized, evidence-based guidance to reduce the risk of chronic diseases and allowing adults to stay independent and just support their overall well-being. So it really has that holistic approach. It doesn't just look at their physical health, but also their mental, social, and emotional health as well. So it'll cover things like screenings, immunization, lifestyle choices, what types of connections do they have in the community, and what's important for them to keep in mind during every stage of life. And it's just really to help them set some goals that are in alignment with their values and just helps them make some informed decisions about the types of things that they might want to be focusing on. And I think the last thing that I want to just build off of Jennifer, I think I'd be remiss not to mention this, but just around home care health professionals in terms of the lack of funding there and the lack of fair compensation. This is something that's affecting primary care as well. It's not just home care, but primary care providers there's quite a significant wage gap between primary care and other sectors like Jennifer mentioned. And it makes it really difficult for us to be able to recruit and retain those skilled and qualified healthcare workers that we so desperately need in our communities to have a sustainable workforce that can provide all of these great services to our communities that contribute to quality aging.
It really does come back to workforce at the end of the day. And again, it's the population you're serving, but also who's going to be there to serve the population. Jennifer, you touched on innovation and technology. I'm curious, on one of our earlier podcasts, we had the Vector Institute coming in and talking about how remote monitoring, how technology is evolving and really supporting new approaches to care where you maybe have your specialists in your urban center, but they're actually monitoring people 200 miles away. As you think about system innovation and some of the opportunities for disruption, as we think about all of these different pieces, what are you seeing? And do you see technology as presenting more of an opportunity to support communities across the province?
I do think that technology has a role to play. So I've been talking a little bit about what we've heard from patients and the public, and I probably should contextualize that those remarks are really based on some work we did over 16 months, hearing from nearly 10,000 people across the country in our initiative, Our Care. And one of the things we did hear from people was that, they want to have virtual care, but integrated with in-person care. And in particular, we did engagements across the country, including in provinces like Manitoba and Nova Scotia, where there are really large rural and northern components. And they wanted to see technology in particular being used to bridge urban-rural gaps and to support people from rural communities to have access to care. Of course, they're describing people having to travel long distances, and why do they need to travel long distances if we can do some of those things virtually or remotely? There's also the opportunity for potentially mobile care as well. So I think they brought those examples up as well. And I think we should hold that together with the virtual care option. So what might that look like? What's kind of already out there? There are already examples of technologies where, for example, you can look in someone's ear remotely or listen to their chest remotely using the technology. There are also some really great examples where you could have a physician that's based in an urban area work with health professionals like nurses or a paramedic that's based in the rural area, and have the other health professional that's in the rural area is providing that in-person touch point. They're potentially examining the patient, supporting them to connect even virtually, supporting the equipment that's needed, etc. But then they have that expertise of the physician who may not be there on site. And so we see some great innovations across Canada. And I'll give a shout out to one of my colleagues, Jonathan Fitzsimmons, who has done a lot of work in Renfrew County. It really is using physicians based in other parts of Ontario to serve this very rural, underserved area in Renfrew County through using virtual technology coupled with in-person care that's provided by other team members who are on site, and also with the concept of continuity of information and relationship. So even if someone is virtual, what we don't want is that to be a disrupted, disjointed relationship, just because if they're virtual, they can still have that continuous relationship that we know is important. So just to say that there are lots of possibilities for using technology to bridge those urban-rural gaps. I think the other piece that I wanted to just also build on, though, from what our colleagues were just speaking about, Jennifer and Michelle, the concept of social isolation and affordability, those are concepts that we've been discussing. And I just wanted to put forward that our system right now is very inequitable. And in fact, some of the people who are struggling the most are people who can't afford privately funded care to supplement the public care that's inadequate, and people who are socially isolated and have no one to advocate for them and are not able to advocate for themselves. And all of the things that we're talking about, I will say, relate to the importance of investing upstream. And it's something that we haven't been doing enough of in Canada. And so if we want any of these things to happen, from technologies to other solutions, we need to fund primary care, home and community care, long-term care, but also preventive care, and not just focus in on the hospital or acute care side of things. So what are the things that are actually going to help keep people well through their lives?
Well, I think that's a great point for us to wrap on. I will look forward to your episode, Primary Focus with Dr. Tara Kieran, coming up. I really encourage our listeners to listen to you as you bring some really thoughtful discussion to how we reimagine the healthcare system more broadly. And there are a lot of lessons learned for us to learn from other jurisdictions like Denmark and the Netherlands, but I think there's a lot that others can learn from Canada and can learn from Ontario and the leadership. Michelle, I think the way you talked about the programs and the services and the preventative aspects of living and aging that you've introduced in Marathon is why people want to move to Marathon. I would actually argue, Jennifer, that equally that's why people want to move to Halliburton too. And it's because of your great leadership. So thank you very much to the three of you for sharing your insights and experience and for a very thoughtful and reflective discussion. This episode was generously sponsored by our sector champion, Point Click Care. Point Click Care is a leading healthcare technology platform enabling meaningful collaboration and access to real-time insights at any stage of a patient's healthcare journey. Point Click Care's single platform spans the care continuum, fostering proactive, holistic decision-making and improved outcomes for all. More than 25,000 long-term post-acute care providers and more than 1,600 hospitals use Point Click Care today. For more information on Point Click Care software solutions, visit pointclickcare.com.